Hello students, this is Dr. Ways and welcome to your lecture on the lower limb joints. So we'll start at the top with the hip joint, and the hip joint is your typical ball and socket synovial joint, which means it's got this ball, which is the head of the femur, inside of a socket, which is your acetabulum, and it's a synovial joint, meaning that it has a complex structure that secretes synovial fluid, and it's freely movable with very few restrictions. It's important to keep in mind that the ball and socket joints, synovial joints in particular, are not bone on bone, but rather each bone, the head of the femur as well as the lining of the acetabulum here, so head of the femur and acetabulum, are both lined in hyaline cartilage. And what we see here, which is a term you may or may not have heard before, is your acetabular labrum, which is a lip of cartilage that's outside of the joint cavity that helps reinforce the joint itself. So here's your acetabular fossa right here, where the ball of the head of the femur would go. And notice that the cartilage around it, known as the lunate surface, is not a complete circle. So on the inferior side, you have this transverse acetabular ligament that helps complete the circle and hold that ball in place when it's put into the socket. So more specifically, remember that synovial joints are surrounded by a synovial membrane, and it's that synovial membrane that secretes synovial fluid that lubricates the joint. Excuse me. So you see that cut away here in green. And another part that's important to see right here is that you have another ligament that's attached to the acetabulum, the fossa itself, and also attached to the head of the femur. In fact, in the lab, when you get to look at femurs, you'll notice that there is a rough spot on the ball of the femur, and that's where this ligament of the head of femur would go. So that physically attaches the head of the femur to the acetabular fossa. So even if it gets dislocated, there is still a tether holding on. And another reason for the importance of that, besides tethering the femur to the acetabulum, is you notice that there is an artery going from the acetabulum to the head of the femur, and it's the acetabular branch of obturator artery. I don't really care that you know that, but one of the reasons that that's important is that ligament is going to help maintain the integrity of that artery so that the femur head can actually get adequate blood supply. So if we close that joint back up, we notice that it is surrounded by a synovial membrane, and you notice that synovial membrane crosses the entire circumference of the head of the femur, the entire labrum of the acetabulum, and the entire neck of the femur. All right, so all of those surfaces are going to be lubricated by the synovial membrane. And another thing to keep in mind about joints, and this is going to be true for all joints, so I'll mention it here and not mention it later, is that synovial membrane is the only place through which exchange occurs. So the joint itself, the cartilage, does not have a direct blood supply. It all comes through the synovial membrane, and the synovial membrane exchanges fluids with the synovial fluid that it secretes. So there's a back and forth. And this is one of the reasons why it takes joints so long to heal, because there's not a direct blood supply. All exchange happens across the synovial membrane. All right, outside of that, you have a set of ligaments that are holding the whole thing together. And remember, ligaments attach bone to bone, and they are fairly strong, really strong collagenous ligaments. And they're named according to where they're located. So you have the iliofemoral ligament, you have the pubofemoral ligament. All right, I'm not going to ask you these. It's not important to remember for testing purposes, but their names are pretty straightforward. And then, of course, their job is to reinforce that joint and make sure that these bones stay together so that the joint itself can function properly. Another thing that I want you to notice about this is if you think about the femur going this way or going this way, you know, extending or flexing, one of the things that limits the flexion and extension is the actual ligaments that's holding the joint together, because these are only going to be able to stretch so far. In fact, they're not very stretchable at all, so they're going to be one of the limitations of the joint, even though the joint itself is freely movable. So this is a repeated slide of the previous one, so none of this information here is new. And as far as the movements go for the hip joint, go ahead and look in your bare bones workbook, and you'll probably do some of these movements in clinical correlations as well, but we'll also review them in the next lecture. All right, next we have the knee joint, and remember the knee joint is that joint between the condyles of the femur and the condyles of the tibia. And so it's femur on tibia, and in between the femur and tibia, just like with the hip joint, the epiphyses of each bone are covered with a cartilage, so you'll see that here in purple. But on the tibia, you'll have this meniscus. And if you remember from chemistry, a meniscus is that little dip, and you're supposed to measure from the bottom in a graduated cylinder. So a meniscus of the knee has a similar shape. If we look at it from a superior view, so down onto the tibia, the meniscus kind of has this figure 8 shape. And on the medial and lateral portions, or on the medial and lateral condyles, you'll have two separate cups, one for each condyle of the femur. So when the femur moves across these cups, it's literally gliding across this meniscus. And the goal of that is to prevent friction, of course. And think of this meniscus as being filled with fluid as well. So as you're constantly walking or moving this joint, sitting down, getting up, this joint is sliding in this little bowl of fluid, if you will, and preventing friction from the excessive movement that this joint typically has. It is also a synovial joint, and all the joints we're going to be talking about are really synovial joints. So it's going to have a complicated structure, but instead of a ball and socket, this is going to be more of a hinge joint. So it really only, remember, hinges only move back and forth. There is a little bit of rotation, a little bit of wiggle room, and we talked about that when we talked about some of these muscles that allow for rotation, but not a whole lot. And you don't want that, because that would compromise the stability of this joint and of your actual leg. Of course, when we think about this joint, we want to make sure that it is held in place very securely. So there are a lot of ligaments associated with the knee joint that help to secure it in position as it's constantly moving back and forth in that hinge rotation, or hinge movement rather. So before we get into some of the more obvious ligaments, first we'll talk about the patella, which is another one of those sesamoid bones. Remember, we talked about sesamoid bones being on the associated with the great toe. There are two of them. But this patella here is right in the anterior of the knee joint, more associated with the femur than it is with the tibia, if you notice its location. And it typically forms around 2 to 6 years of age in children. So any children definitely below 2 and anywhere between 2 and 6 may or may not have a patella. So it's going to start developing with the use of the limbs. All right, and that patella is held in place by the patellar ligament. You have one going down here, or inferior patellar ligament down here to the tibia. And then up here we have the tendon for the quadriceps femoris. So it's not a ligament up here. This is actually connected to the quadricep muscles as a group that are involved in extending the knee. And its function really is to act as kind of like a pulley for the quadricep muscles up here. As you have knee flexion and extension, you're constantly pulling on these tendons, and so this patella kind of moves along and helps, act as like a pulley mechanism. And as opposed to having, this tendon directly connect the superior tendon directly connected to the inferior tendon, or rather inferior ligament, this patella kind of acts as a spacer, protecting these ligaments and tendons from excessive strain. Right underneath, you'll have fat pads that aid in the protection of this joint and the integrity of the ligaments. So other stabilization ligaments include this fibular collateral ligament, also known as the lateral collateral ligament, and then you have another one on the other side called the medial collateral ligament. So the lateral is actually obviously attached to the fibula here, and then the medial would be attached to the tibia. And then within the joint itself, you have your anterior cruciate ligament, or ACL, and then you have your posterior cruciate ligament, known as your PCL. And this ACL is the one you often hear of as athletes having an injury. So this one is one that's commonly torn. But all these ligaments aid to help stabilize the knee joint as it's moving. So in this slide, you see a better picture of the meniscus. So here is one of the cups, and here is the other cup. And what actually makes the figure eight are these ligaments that are holding the two cups together, kind of stabilizing them to each other. And then you have the anterior cruciate ligament, which is called the anterior cruciate ligament because its attachment is in the anterior of the tibia, and the posterior cruciate ligament is back here because it is attached to the posterior portion of the tibia. All right, so another view of the knee joint, this one being a superior view that I tried to draw earlier, but I am not exactly a great artist. So you see the cup here on the lateral side and a cup here on the medial side. Just like you saw with the acetabulum of the hip joint, notice they're incomplete cups, and they're finished by these ligaments that attach them to the bone right here. And since they kind of look crisscross, that's why I said it's a figure eight. And then here we have our ACL, our PCL, and then the fat pad, the patellar ligament, the inferior one, and then there's transverse ligaments holding the cups of the meniscus together as well. And the whole thing is surrounded by this joint capsule. So again, like we saw with the hip joint, the entire thing is wrapped in a fibrous capsule. Looking over here, we see it again. Notice that just inside of that fibrous capsule, we again will have this synovial membrane, and again it's the synovial membrane that blood supply is attached to, and will help create that synovial fluid, but also acts as the only medium between the joint and the blood vessels. So again, joints don't generally have a direct blood supply. The blood supply is through exchange with this synovial membrane. So here's another view of the superior view of the knee joint, showing the same things that we've shown before, but this is from your bare bones workbook, so just some continuity there. And then over here, what I want you to notice about this is here you have your quadriceps tendon, your patellar ligament, and then your patella itself, but just anterior, not superior, just anterior to the patella, you have this prepatella bursa. And bursas are, bursae, plural, are little sacs of fluid that basically lie between bony prominences and the skin, or between structures within a joint that help protect the joint itself, the bones of the joint. And so you have this prepatellar bursa right here. You have another bursa just inferior to that on either side of the patellar ligament that will also aid in cushioning that ligament and preventing excess wear and tear. Here's another view of your knee joint, and here we're showing the tibial collateral ligament, also known as the medial collateral ligament, as well as the patellar ligament right here. And the three tendons for your gracilis, or sartorius gracilis, and semitendinosus, that's part of your pes anserine that we mentioned before on the medial side of your knee. And then if we look over here, we see again that medial collateral ligament, the lateral collateral ligament, the patellar ligament, and then the fibrous capsule that surrounds the synovial membrane of the knee joint. All right, a posterior view of the knee joint, where we see our popliteal ligament, oblique popliteal ligament, and the popliteus muscle, and where it attaches. Not that those are important to this particular lecture. And as far as the knee joint movements, again, see your bare bones workbook, and you will probably also do these movements in clinical correlation, and we will also discuss it in the next PowerPoint lecture. All right, now we're moving downward to the ankle joint, also known as the talocrural joint, because it is the talus right here attached to the bones of the leg, because anything crural is referring to the leg, or it could refer to the thigh, but here we're referring to specifically the leg. All right, notice the cartilage on the surface of the talus bone, and you're going to have cartilage that's here with the lateral malleolus, medial malleolus, as well as this flat part of the tibia right here. And if we just take the talocrural joint alone, notice that it is a hinge joint. So this will allow your ankle, or your foot rather, and your ankle to perform plantar flexion and dorsiflexion. And then it'll be the articulations between the joints of your tarsals that will allow your ankle to roll in multiple directions as opposed to just a hinge. So on the medial side, there are ligaments that hold the joint together, attached to the tibia as well as to the bones of the tarsals. And of course, they're named according to where they're connected to. So again, not that you have to know specifically what the names are, but they're named according to what they're attached to. Same thing goes with the lateral aspect. Here you have the fibula, and then the ligaments that attach the fibula to the tarsal bones, and they're named accordingly. And just like with the previous joints, movements you can see in your bare bones workbook, in physical exam or clinical correlations, as well as the next lecture we will be doing.